We have the honor to have with us Professor Gulluoglu Bahadir from Turkey. It's the professor of Marmara University. Yes? Please. Thank you. It's the lecture is Stage 4 disease. What is the surgeon's role?
Thank you very much, dear chairs.
You're welcome. Thank you.
It's an honor for me to be here. This is, I think, the 10th time I'm coming to Athena. It's like my home. I always say this. In my whole career, the first time when I came to 1995 in Athens was my first English-speaking conference and my first time to give a presentation in my career. So it has a special place for me, in my heart. So today I will be talking about stage 4 disease for the surgeons. Normally what we know about this is the standard of care for years, that the stage 4 disease is a metastatic disease. It's an incurable disease. It's an incurable stage for the patient. So for years we know that there's no role for surgery for these patients. But of course, in a practical way, when you see your patients, not always you do a systemic staging. So when you see a patient in an early stage, not even in advanced stages, of course, you may start by doing surgery, but then your oncologist may do the systemic staging, and they may find that there are some, distant metastases. So because we have those patients, and there are lots of researchers all around the world, and they just collected those patients' data and made, studies retrospectively, and they found that there might be an advantage of doing surgery to the primary in those metastatic patients. So because all those studies, without exception nearly, they found this advantage, the survival advantage in these patients. Then, early 2000, people just rose the idea of whether to, conduct a prospective randomized studies on these patients with the stage 4 metastatic, de novo metastatic cancers. So we so far have 6 studies. I'll be just going over all these and make you to read between the lines, because not all studies are uniform. Not all studies are giving the same answer. So let's go. What we will consider when we are seeing these patients. The first one is the efficacy. Is there any advantage to do surgery in these patients? What about the timing? What about the extent of surgery? Should we only concentrate on the tumor itself, or should we do radiotherapy? Should we do axillary staging or dissection? Or should we do other things in these patients? So the second thing here is the scenarios. The first scenario is the local regional surgery, because as a surgeon, if I am seeing a patient with a distant metastasis, let's say a single metastasis in liver, should I do surgery at that site as well? So this is another question, and I'm sorry because I cannot give you too much data about this, because all the data are retrospective on this matter. The first thing is the upfront surgery in de novo distant disease. You see the patient in the metastatic stage, should we do surgery in the primary? The second one is you first give the primary systemic treatment, you have a good response to the distant side. Should you do a primary surgery in these patients, like you're doing now as a neoadjuvant chemotherapy in the advanced stage, but not metastatic? And the third here is the resection of the distant disease, like liver and lung, because we only have some data on these metastatic sites. Should we do at admission, in synchronous with the primary surgery, or should we do, for example, you made the surgery 5 years ago, you did a good surgery, but after 5 years, you saw the metastasis in liver. Should we go on to do a liver resection in these patients? So let's start with the first question. There are, as I told you, 6 studies so far, but they're all different because there are 2 mainly methodologies that they follow when they are designing their trials. The first one is they first give the primary systemic treatment. According to the response, if they have a good response, they randomize their patients into 2 arms. One, the surgery, the other one going on with the systemic treatment. And the other 3, including the Turkish trial, they randomized at the beginning, at admission. So regardless of the response, because they don't know the response to the systemic treatment, they randomize patients into 2 arms. First, surgery, and the other arm, no surgery, but systemic treatment. But of course, whatever they do when they do surgery, they also give systemic treatment to these patients. So for the design 1, which the patients receive the systemic treatment, there are 3 studies. The first one is the very first one from 2015 from India. They randomize their patients after they receive 6 months of as a primary systemic treatment. As you can see, there is no difference in survival, but the follow-up is very, very short. Do they need a longer follow-up? I don't think so, because as you can see, in 23 months, the survival, even in the systemic treatment arm, is very, very low. So, but is it surprising? No, it's not surprising, because when you see the characteristics of this cohort, the patients are mostly with a heavy disease burden. 94% of them had an unresectable breast cancer at the beginning, and the complete resection we don't know. They said only surgery, and there's a substandard systemic treatment, which means that 20% of the patients nearly are HER2 positive, but they didn't receive anti-HER2 treatment. And as you can see, I showed you the overall survival is very low in both arms. So, and then they looked for if there is any difference in subgroups like oligometastatic disease or hormone-positive subgroups, and they didn't find any difference in all those subgroups. Only significant finding was the local recurrence progression-free survival was better in the surgical treatment arm, which is predictable, of course. The second study came from the United States and also North America. Some Canadian centers are included in this EA 2108 study. They randomized 256 patients after they receive 4 to 8 months of systemic treatment. If they give a good response, that means a stable, without progression, if the treatment gives a response in this by means of minimum stable disease here, they randomize their patients into 2 arms. So the follow-up is nearly 5 years. Again, overall survival, there is no difference between 2 groups. Again, with the same result with the Indian study, only the local recurrence progression rate is lower in the surgical arm. Also, they found that the overall survival is not different in hormone-positive and HER2-positive patients, but the survival is worse in the triple-negative cancer patients when they do surgery here in these patients. But again, of course, they have limitations. A little bit, similar to the Indian study, nearly half of the patients are T4, stage with the N2 and N3 disease. Again, 1/3 of the patients had a skin and chest wall involvement. Normally, you don't think any surgery in these patients. You start systemic treatment. But they, because having a response in these patients, they randomize their studies. Again, 1/3 of them had bone-only metastases. Rest are the other metastatic sites. And only 16% had an oligometastasis. Because we'll see some studies that because this distribution of the disease is very, very important, because if you can see in the Turkish trial, most of the patients are oligometastatic, and some are only bone-only metastases. So there's no difference in less advanced in the oligometastatic and bone-only met subgroups. But as you can understand easily here, when you just make the subgroups, the number of patients in these subgroups are going down. So because of this diminished number of patients, the power of the analysis here cannot be regarded as strong. So again, in this trial, 14% of the patients did not undergo surgery in the local group. So, and again, in the 17% of the patients in the systemic treatment only, they had surgery. So there are crossovers almost the same. So 8% had an incomplete resection, and 16% had a surgery just after 3 months. They wait for 3 months and they did the surgery. And again, 16% did not have radiotherapy after breast-conserving surgery, and 42% of the patients did not receive radiotherapy after mastectomy, either to the lymph node or the chest wall. So when we come to the last trial, which is the Japanese trial, not published yet, but the results were presented the last ASCO in June 2023, they randomized nearly 400 patients. And as a result, again, there is no overall survival difference between two groups. But here, it is similar to the previous two studies. Local progression-free survival is better in the surgical arm, which is 63 months in the surgery arm and 20 months in the systemic treatment arm. But one tiny thing, which is just a subgroup analysis, in the arm B, which is the systemic treatment group, the surgical group, the patients with incomplete resection had poorer outcomes than those in whom the resection was complete. So this is also very important. But another finding here, which is significant, when they looked at the subgroup analysis, again with the low power, but they found that the survival is improved in ER-positive tumors, premenopausal status, or single organ metastasis when they did surgery in this group. So this is the only study that's showing that a subgroup had an advantage when they have a surgery. So the second design is just do the surgery straight at admission. The first study from Egypt, which is just a very small population, they found that the survival, again, similar in two groups, but they also found that when the size of metastasis is increasing, or if there is a non-bone metastasis there, then the survival is worse in these patients. So the sample size is very small, as you can see, only 60 patients, and the follow-up is very short, like 15 months, even shorter than the Indian study. Coming to the Australian study, again, this is an unfortunate study because they aim to recruit nearly 300 patients, but they can only do for 90 patients. That's why they have to stop this prematurely, this study, but they reported their result after 38 months of follow-up. And they didn't find any survival difference in both groups as well. So it's an early closed study. It's underpowered. It's, again, more advanced disease in the surgery arm, so there's an imbalance as well here. And 20% had an incomplete tumor resection, which I will explain this why it is important. And only 20% received radiotherapy to breast and chest wall. As you can remember from the Japanese trial, that in that individual group, if they have an incomplete resection, they had a worse outcome compared to those who had a complete resection. So this is one of the findings that I can say from these randomized trials, that the complete resection is really important in these patients if there's a place of surgery in de novo stage 4 disease. So coming to the Turkish trial, also there are lots of limitations and lots of defenses against this trial. Here, this is the trial which has the longest follow-up. So at the end of 10 years, which is 120 months, there is a 14% of absolute advantage of overall survival when the patients receive surgery. So again, surgery was found to be superior by means of local regional progression. If the patient receives a surgery, the progression is 1%. If the patient receives only the systemic treatment, it is 14%, and it's also significant here. So the overall survival is longer in the surgery group with respect to hormone-positive tumors and solitary bone-only metastasis. So this is one of the significant findings, which shows that if the disease is, not advanced, although this is a de novo metastasis, it's a stage 4, maybe in future we should maybe reclassify the stage 4 disease here. For example, bone-only metastasis or oligometastasis in only bone or with other visceral metastasis, we may reclassify and may find a place for surgery in these patients. So the limitation for this study is, of course, because this is a randomized study, you do not expect any imbalance in the two groups. But here, there is more favorable tumors in the surgical group. So less patients with triple negative and HER2 positive tumors in the surgery arm. So overall, this is a very recent meta-analysis. Again, they showed that there is no significant overall survival advantage when you do surgery in these de novo metastatic patients. But again, it is a heterogeneous group. I mean, there are studies with advanced disease, and there is a study like Turkish study, only 60% of the patients are de novo, only bone metastasis, only one metastasis in the whole cohort. So, but another meta-analysis showed that, this is interesting, I've just put this here, when you stratify according to the design, if the patients who are randomized after having the systemic treatment, they didn't find overall survival advantage. But the second design, this meta-analysis says that there might be a survival advantage if you start surgery in the beginning. But one absolute finding from all these 6 studies that if you do surgery in these patients, you have a significant advantage of extending the progression-free survival. So this is absolute. So after these studies, Turkish surgeons just started to recruit patients for only bone-only metastasis patients. This is a prospective registry trial. Started in 2014. The only patients, this is not visceral metastasis, not oligometastasis. This is a bone-only metastasis, but the less than 4 metastatic sites. So they randomized, this is another randomized, they made the cohorts into 2. One systemic treatment group only, the other one's the local regional treatment group with the surgery, and including the radiotherapy and with the clear margin as well. But it could be after systemic treatment or starting at admission. So median time from the systemic treatment to the local regional treatment, which is surgery, is nearly 194 days. So as you can see on the table, that the solitary metastasis is more in the local regional treatment group, and again, more patients with oligometastasis in the surgical group. So it is obvious because there could be a selection bias when you do a prospective registry trial like this one. But at the end, they found that overall survival is better in the surgical group, local recurrence-free survival is better in the surgical group, and the systemic disease progression-free survival is better again in the primary for the surgical group. But as you can see on the table, on the figure here on the right side, you can see that if they start with a systemic treatment, and probably because they have a good response to the systemic treatment, they offer surgery to these patients. So this group did better than the other groups. So this might be a message, for example, here in this bone-only metastasis group. So again, in this group, surgery had an impact on survival in the hormone-positive ones, or HER2 positive ones, but not in triple-negative patients. Again, another message. So the metastatic-only, the bone-only metastatic group here from this prospective registry trial, we can see that when the number of metastatic lesions are increased, then the survival is going down. So the contribution of the surgical treatment, even in those with the more sites in bone, again, there is an advantage, is a benefit from having a surgery in these groups. But the maximum benefit is seen in those with the limited bone metastasis. So there are lots of criticism over Turkish trial from other trials. For example, the American says that, well, we do this systemic treatment and we got, at the end, the median time for reaching the 50% of overall survival is longer in our patients, but it is 20 months in Indian trial, which is low. That is what is normal because they have an advanced disease. But it's also 36 months in the Turkish trial. So even those who had surgery, still they have worse survival when you compare it with our systemic treatment group. But it is normal. Why? Because they started with systemic treatment. They only selected the ones who responded to their treatment, So it is normal to have this longer survival in these groups. But the Turkish trial started at admission with the surgery, so there were some patients probably which worse. So this also, because in overall this isn't just an average number, that is normal to have a less survival in this group. So the French trial, this is a registry trial, again from France, which was released recently. They also found a better outcome. Again, this is just real-world data. The younger patients, the hormone-positive and HER2-positive tumors, the patients with less than 3 metastatic site, non-visceral metastasis, which means bone metastasis, and the surgery of the primary were the significant factors which had the better prognosis in these patients. Also, another study from the National Cancer Database, they found that survival is better if the surgery is done after systemic treatment in hormone-positive and HER2-positive cancer patients. Again, this is a registry trial as well. But everything, because we need to meet in the minimums, so everything shows that if the disease is minimum, and if you start with a systemic treatment, and if the patient is young, and if the patient has a hormone-positive or HER2-positive patients. Why these are important? Because these patients, these subgroups, had a good response to the systemic treatment. So when considering the surgery, you shouldn't exclude the fact that the systemic treatment also had a significant impact on these patients' prognosis. So why should we have an R0 resection? Because there's a meta-analysis showing that the R0 resection had a benefit, providing a benefit in those patients with the negative margins. Also the radiotherapy, again, another study from the SEER database showed that if you're applying radiotherapy to these patients, not only to the after breast conserving surgery or to the regional nodes, again, it provides a survival benefit. And for the role of axillary dissection, another database study, this is a registry trial, also showed that if you're doing a sentinel node biopsy, which turns out to be negative, you can leave the axilla intact, but if there is a positive axilla, then you should go on with the axillary dissection because this provides a benefit in these patients as well. So as a conclusion, it's an intermediate conclusion. I have 4 minutes. Surgery at primary should not be a part of the routine clinical practice. This is sure. So it might be performed in selected patients from the perspective that I gave you from 6 studies and also some prospective registry trials. Those with a low metastatic burden, with a favorable tumor subtype, and the cancers who might respond good to the systemic treatment with a longer life expectancy, which means the young patients. So the R0 resection in the breast and axilla and regional radiotherapy seem to add clinical benefit from those retrospective registry trials. So this is a slide from the previous ABC consensus meeting in Lisbon, and it's the Advanced Breast Cancer Conference. They voted for this surgery in these patients, and they said that there are some examples they gave it, like symptomatic primary site, so you do surgery for palliation, progression of the primary tumor when distance is controlled, and oligometastatic disease to try to induce a complete remission to provide no evidence of disease, because if you don't see the disease in the breast, because you gave the treatment, systemic treatment, everything is in regression, so only remaining site in the breast and the axilla, so you may do surgery here, or no evidence of disease except the primary tumor, as I told you, to try to induce a complete remission. So they voted, and 98% of the people there in the consensus committee voted for this, for surgery for the primary. So what is the impact of resection of distant metastasis? Just a few words for this, for 5 minutes. For the liver metastasis and the pulmonary metastasis, there's no evidence for doing a surgery synchronously to the breast and to the metastatic site. So I cannot give you any data for this. But I can give you some data, retrospective data. If you have a good, in remission, you do the surgery in the beginning, it's non-metastatic, but in time, when the metastasis metachronously just occurs after a period of time, is there a way to do, is there a place for doing a liver metastasectomy in these patients? So there's one systemic review and meta-analysis, just included 9 studies here, and they found that overall the metastasectomy in liver decreases the mortality by 30%. Probably they're good patients because there's absolutely there's a selection bias, but there might be a, a meaning of having this result at the end. So there should be a subgroup which might have a benefit, from this liver resection. So again, another study showed that if the axillary node is positive, it's a bad sign. If it's an ER negative tumor, it's a bad sign. If there are multiple liver metastases, it's a bad sign. If it's the size of liver metastasis is large, it's a bad sign. If there's a short interval between the first surgery and the appearance of the liver metastasis, it's a bad sign. So again, if there's a positive margin in the liver, it's a bad sign. And if there is an extrahepatic disease other than liver, multiple metastasis, it's a bad sign. So there might be a selection criteria, which is just taken out from these tables for liver metastasectomy, is if the tumor is a hormone positive and zero primary cancer, if the disease just happened to seen the distant metastasis after 2 years, is a single focus, a small focus, resection with negative margin, and absence of any extrahepatic disease, there might be a place for hepatic resection in these patients. But not less. Here, I may give you another study here from the MD Anderson. So they made also a registry trial, and they also found, in addition to hormone positives, HER2 positive patients also may have an advantage by having a liver metastasectomy. So it comes to the same point. If you have a disease which is responding to the systemic treatment, so this may give you an advantage by doing a surgery. At the minimum, you can prolong the progression-free survival in these patients, which is very important for the quality of life, of course. Is it really related to the overall survival? I can't tell you that. But I can tell you that if there's a prolongation of the progression-free survival, when you put yourself into your patient's boots, you would prefer to have this. Even in a time when the systemic treatment comes into the market and saying that there is only 4 months of an improvement in median survival, when you're saying a surgery like this with a less expensive, but of course a little bit more complication, but having maybe a more benefit in your patients, maybe you may consider doing surgery in these patients by doing a metastasectomy in the liver or the lung. So the last slide for the pulmonary metastasis, again, we have the same result. If the interval is longer, if there is a complete resection, if it's a single metastasis, if it's a hormone-positive tumors, they found that there's a survival advantage in these patients. So as a conclusion, I have 2.5 minutes. I'm just sparing some time for you to ask questions. I can tell you that there might be a place for doing a surgery for the stage 4 disease at admission for the primary, or in time after your surgery and having having some distant metastasis as a metachronous metastasis to the liver and to the pulmonary in the lung. By doing these surgeries, again, at the bottom line is that you have an advantage of extending the progression-free survival, and you can make a comparison with the systemic treatment in this basis. So it is a multidisciplinary decision. It's not only the decision of the surgeons. So I'm sure that the medical oncologists, radiation oncologists, the pathologists, and the radiologists, all together with the breast surgeons, should think once more by individually, case by case, of course. But I think at the bottom line, there is one subgroup which really might have a benefit from surgery in this subgroup as well. Okay, thank you very much.
Thank you very much, my friend Bahadir, for your excellent talk. This friendship has been for a long, long time. And just to remind to everybody that Professor Bahadir is a member of the panel of experts at St. Gallen Breast Cancer Conference. Excellent talk. Thank you very much. Grigoris, I'm not sure if there's any question from the floor. The microphone is yours. Thanks a lot for the invitation.
Ερωτήσεις? Questions? Professor Kondos.
Thank you, Bahadir. Thank you for being here. I understand that at the moment we have more questions than answers for these patients. And I understand that not all metastatic patients are the same. So it's not one size fits all. You have to discuss and perhaps personalize individualize the treatment to each patient's and tumors characteristics. A take-home message, would you prefer to consider surgery on these patients after having secured that the metastatic disease is stable? Mm-hmm. So I'm asking, what is the best time of the surgery of the primary site on these patients?
Well, that's an excellent question. As you said, that there are more questions than answers in this, field. So what I can tell you that, from my opinion, of course, there are 4 scenarios. One is you see the metastatic patient at admission. Should you go for the surgery in the beginning? I would not. I would wait for the result of the systemic treatment starting from this beginning. And your question comes here, and you give this systemic treatment for, let's say, minimum 4 months, and you say it's stabilized. There's no progression in the distant site. Is that correct? And there is no, again, a progression in the primary site. So what should we do here? So this is a very difficult question. The easiest one would be, okay, Bahadir, you give the systemic treatment, everything vanished in this systemic part, in the de novo part, and there's only a remaining tumor in the breast. I would do surgery here, because there's only one visible tumor, and that's in the breast. So it is like giving a neoadjuvant treatment in an advanced disease with no metastasis, determined in the beginning. Because what we are doing now, and when we see, lymph node metastasis, we start with neoadjuvant chemotherapy. Then whether we have a response or not, we do surgery at the end in order to understand whether there's a response to this, because we change our systemic treatment. So here, the only easiest answer is that if I would have the remission of metastasis and then I do the surgery in the breast, 2 things that I would accomplish. One, I would control the disease in the breast for the salvage, right? For the salvage, not for the treatment, maybe. The second one is if there's also a complete remission in the breast, then the fate of patient would be changed by changing the treatment strategy here, like you have it in neoadjuvant treatment. But coming to your question, if you have still the tumor in the liver, and there is also the tumor in the breast, so I don't think there is a survival advantage by doing a surgery in the breast. That's only controlling the disease in the breast. Again, this patient's survival will be dependent on the appropriate systemic treatment. So the only message that I can take from this case that our systemic treatment is not appropriate and is not adequate for, at this patient with this treatment.
Would you irradiate the breast?
Good question again.
And would you do an axillary clearance?
That's a good question. Again, with this case, right? With this case.
Yes.
Well,
this case.
You had the answer. I didn't prefer to do surgery to the breast, therefore I wouldn't do radiotherapy, and I would, if, of course, as a progression, then I would do surgery. But if I would do surgery for the progression as a salvage, should I do a radiotherapy to this patient? Maybe this would be a more relevant question. Well, it depends, because why? Because if the disease is hormone positive and HER2 positive, and still we have an advantage, we have an chance to treat this patient with different modalities, then I would radiate to control the breast. But for the triple negatives, I wouldn't do. Yanis, there, here.
I would like to know how important is consideration of the quality of life in your decision in the gray scale.
Yeah.
To operate or not operate.
Yeah.
It's important?
Well, it is important not from my side. It's important from the patient's side, because this is very critical. Even, it's not my decision only. It's not decision from the multidisciplinary team meeting or the team members. You should discuss this with your patient. If the patient, because I have such patients, some says, if there's no advantage, I don't want to get under any operation because there's some risk for the complications. If there's no advantage, I don't want to lose my breast sometimes because you need to do mastectomy. But some patients said, it's not good to feel that still tumor is there. I want it to be removed, at what expense? So again, here the patient's decision is very important. That's why I should underline that shared decision-making has the paramount importance here when deciding what to do in the next stage. But it is important, quality of life. From my side, if I would be the patient, from my side, it would be important.
Thank you.
You're welcome. Sophocles.
Well, I would focus mostly on the skin condition. So if you have a tumor that's actually progressing over time,
Yeah.
and you have stable metastasis, would
Yeah.
you consider the surgery just for the local control? Because quality of life is really affected by the
Yeah.
skin lesions, isn't
Yeah,
it?
yeah, yeah.
So that's my question. It dependent on the overall survival. We need to think about quality of life, isn't it?
Exactly,
And
exactly.
My next question is about
sometimes,
the...
sometimes, when I give this lecture, you think that only the low burden disease should have a, surgery chance. But here, this is on the other hand, this is another marginal, case in the other side. So this is an advanced case with a skin involvement. So here, again, there is a role of surgery, but for the salvaging, for just removing the tumor, for the bleeding, for the bad odor, it's not always, easy to live with that. So of course there's a role for surgery, but only for salvaging. It's not for overall survival.
So, and the second part of my question, this special type of metastasis, the skin lesions.
Yeah,
okay?
yeah.
So you don't have any distal lesions.
Yeah,
you have only these lesions in the skin.
Yeah.
You give some chemotherapy and you see that these things are shrinking down. Would you consider surgery in these cases?
I mean, is it a non-metastatic patient or is it a metastatic patient?
Well, we consider the skin lesion as systemic.
Oh, I see. Right. Okay. So I didn't think like that. All right.
lesions,
Okay.
yes.
So here, again, I would think that it's like a neoadjuvant setting, There's no metastasis, distant metastasis. It's only a skin metastasis. So here, we don't know exactly if, of course, there is a full response, a complete response. Still, we do surgery now. Maybe in time, we will just give radiotherapy to these patients. But you're asking, there's a remaining tumor, right, in the breast, but there's no skin infiltration anymore after systemic. Is that correct?
Yes.
Right. So here, well, I may say that we still do surgery in these cases because that is the only maybe moment that you can catch the disease at that stage. And maybe a tumor will, again progress in time, and that time systemic treatment will not be enough. So that is the only time that you can catch. That's the window of opportunity that you can resect the tumor for salvaging again, not for overall survival.
Thanks.
Yeah.
I think we finished.
Thank you very much. It's